So today we'll be sharing some background on our Network of Care grant, the Network of Care implementation grant that we've received, and then jump into reviewing the release for proposals, as well as the application, and we want to make sure we leave time for questions as well. So I wanted to share some background that I think is really helpful in understanding kind of how this Buffering Services grant fits into the bigger picture of the ACEs and resilience efforts happening in our county. So many of you might be familiar with the ACEs Aware initiative. This is an initiative out of the Office of the Surgeon General, and this initiative is really kind of first in the nation in terms of efforts to screen patients for adverse childhood experiences and improve and save lives. It's a part of the governor's California for All initiative, and it's really striving to create a better world for children, families, and communities across sectors to prevent and address the impacts of adverse childhood experiences and toxic stress. And so some of you may know, but just to share, a lot of work is happening in our county in alignment with the ACEs Aware initiative. The Pediatric Resiliency Collaborative received a core training grant and supplemental training grant. This was the first round of grants awarded by the ACEs Aware initiative. And we are excited to announce that we now have a ACEs Aware certified core training grant, core training for providers. So this is an opportunity for providers to attest to completing an ACEs Aware training and also receive continuing education credits. Also happening in our county, the Community Health Centers for the Central Coast received a provider engagement grant and a peer learning grant, really focusing on their behavioral health specialist. Then the Kids Network received a provider engagement grant, and this went to support the Bridges to Resilience conference. I hope folks had a chance to attend that last week. And then also now Cottage, on behalf of the Pediatric Resiliency Collaborative and Resilient Santa Barbara County, has received this Network of Care implementation grant. And this is the second round of grant funds released by the ACEs Aware initiative, really building on that first round of grants that focused on getting providers trained and really expanding ACEs screening. And now we're looking at how do we prepare a network that can really address the needs of children and families once ACEs screening is happening widely in our county. So, we're using this term network of care, and we've received guidance from the ACEs Aware initiative, and they define a network of care as a group of interdisciplinary health, education, and human services professionals, community members, and organizations that are supporting adults, children, and families to provide access to evidence-based buffering services. And what they mean by buffering services are really those services and resources that support to address the toxic stress response. And so also, when we think about how to build a strong network of care, this includes, having a network that's ACEs informed, trauma responsive, focused on resilience, multidisciplinary, and improving access to buffering resources and support. And so the ACEs Aware initiative has provided this stress buster wheel, which identifies examples of these buffering services. And so to the right, you'll see examples of evidence-based strategies to address toxic stress, including quality sleep, balanced nutrition, physical activity, mindfulness, experiencing nature, mental health care, and supportive relationships. So our network of care implementation grant activities are focused on creating a grant leadership team that can help sustain these efforts in our county. We're also working to expand access to network of care by expanding our PeRC model, but also providing that connection to the resilient Santa Barbara County partners and efforts. So it really is looking at expanding the pediatric resiliency model around connecting clinic providers to service providers, but also expanding on the work that Resilient Santa Barbara County has done to really build this trauma-informed network of providers who can respond once families are being screened by clinicians. We're also looking to identify and implement an IT platform to support referrals and navigation. Our dream is to identify, with input from our community partners, a platform that can either integrate with existing platforms that partners are using, or could be a substitute for those who are looking to transition to a new IT platform. But essentially, we would all be able to track and identify what resources families have participated in, and hopefully some outcomes of those engagements as well. And so I think there will be a lot of work happening here to ensure that this is a platform that can work for a majority of our community partners. And then lastly, we're looking to provide trainings and resources and support to enhance community capacity for trauma-informed care. So today's RFP really falls in that second grant activity around assessing our network of care and expanding. Currently, our PeRC clinics are connected to a resource navigator and a therapist. And so what we're hoping to do through this grant is expand access to other buffering services that can help address the needs of our families that are being screened through our clinic partners. And so now we'll jump into the RFP itself. So the purpose of this RFP, as I've mentioned, is really to strengthen our trauma-informed network of care by expanding access to community-based services that can help interrupt the toxic stress response for our families, our patients and families of our PeRC participating clinics. Some key principles that are helping to guide this grant program include coordination. We've seen really great success with our small PeRC model, which is connection to a navigator and a therapist. But really that communication between the clinic partners and the service providers is really an essential piece of this model. And so we're looking as we add additional services to ensure that that coordination continues. This currently happens through monthly meetings and other activities to support coordination across the different entities, and we're hoping to continue that through this grant. Health equity is also an important lens that we're embedding into this grant work. And we're asking that applicants consider whether their processes and procedures are inclusive of all populations and identifying those most vulnerable. An additional principle for our grant program is evidence-based and evidence-informed. And what we mean by this is that you're using research, data, or lived experience of community members to inform your programs, and that you're able to demonstrate positive impact as a result of your program. So being able to share any literature, research, or data that supports your programs will be essential as you're putting together your applications. And then lastly, sustainability. This is important because we're hoping that these programs that we put in place will be sustained, though we understand that this is a short grant cycle. We're hoping that you'll be able to demonstrate in your applications how you're thinking about sustainability. So we're asking that when we think about the response to ACEs, we see this really in three areas. Primary prevention, which is preventing ACEs by educating parents and providing support to families. And then the secondary prevention looks at early recognition of ACEs and providing support to prevent toxic stress. And then tertiary prevention is around early evidence-based interventions to mitigate the responses, to mitigate the toxic stress response as families are being identified. And so what that looks like in terms of potential programs or services that could be offered as a part of this grant program. In terms of primary and secondary prevention, this may look like education programs about ACEs and toxic stress and mitigating strategies. Again, looking at that wheel we shared earlier for those examples of those mitigation strategies. Could also be community-based programs that provide access to toxic stress mitigation strategies. So not just the education around those mitigation strategies, but actual connection to any of those areas within that stress wheel that was shared previously and is also included in the RFP. Parent education regarding child development or parenting support through classes or peer mentoring. And then lastly, direct connection to community programs, direct connection of community programs to clinics. So having some in-clinic services available to patients and their families. Around tertiary prevention, these strategies may look like parent and family supports around behavioral health needs through support groups or peer mentoring. Individual counseling and therapeutic services is not an allowable service through this grant program. This grant is being funded through Medicaid dollars, and so any services such as counseling and therapy that could be reimbursed through Medi-Cal are not allowable. So other types of behavioral health services like support groups and peer mentoring are allowable through this grant. Another example of the tertiary prevention could be community health workers, promotoras, connecting families to services, care coordination support, social services support, and domestic violence support services. Again, any services that currently aren't being reimbursed through Medi-Cal. I think I just want to pause here before I go into kind of the evaluation and what's expected in terms of data reporting to see if there's any questions about the types of services, programs we're looking for, anything we might be able to clarify as you're thinking about your application.
Hi, Alma. This is Veronica Binkley from Harding. And one of the things that I was hoping to be able to tap into this grant for was to help support our friendship groups, which is a tier 2 intervention for students, using our partnership with the university, who trains undergrad students in kind of acknowledging feelings and strategies to deal with those feelings, positively, and then how to communicate effectively. Would that be something? I mean, because typically the students that we work with do have high ACEs, and they do need support and just being a good friend.
Mm-hmm. Yeah, so it sounds like what this could look like is that after families have been screened and identified that the child may need some additional services, one of those services could be making sure that they're connected to these friendship groups, which is kind of like a group, I don't know the best, it's like behavioral health services, but kind of in a group setting where you're working with students who have kind of maybe mild behavioral health needs to address those in a group setting. Am I explaining the groups correctly?
Yeah, I mean, it could be mild to moderate, and it's just being able to practice strategies with each other, and just to build productive strategies for interpersonal relationships.
I think that does fit within this program, this grant parameters. I think one thing to think about and be able to kind of address in the application is that connection to the primary care provider, kind of what that might look like, what the provider might need to, how that coordination might work. But I want to see if Barb or Peggy or Andrea have thoughts here as well.
Yeah, I would say it sounds like it's a good fit with supportive relationships, which is on the stress busting wheel. Certainly kids need to have those skills as well as the adults who are trying to work with them. So it sounds like that would be a good fit. But yeah, thinking about the connection to primary care and how that communication might happen, and if a child is identified, would there be a referral process, or are all kids just automatically enrolled in those groups? It doesn't have to be just patients of the clinic. It can be other kids as well, but just making sure that those kids that are patients that need that service would have access to it.
Okay, so I guess I need some clarification on when you say that our patients, so would we be working in providing these services? Would we be intaking students? Because I'm a principal at a school. Would we be intaking students who are in your care facility?
Not necessarily. I think we're saying, so, and we'll share in the RFP, there's a list of clinic partners, and we're saying, in addition to providing these services broadly, are there clinics that you could receive referrals from? So looking at the list of clinics, we're working with the Santa Barbara neighborhood clinics, we're working with Franklin and some other public health clinics. So if a student from Harding is screened by their pediatrician and a referral is made, is there a process, or could you develop a process that would allow for those students to then be enrolled into these groups in addition to those students who are already participating?
Right, and we actually have a system in place. So that really provided clarity for me. Thanks. Thank you.
Other questions? I think this is such an important part. I want to make sure we are clarifying and demystifying this RFP and application. I know the turnaround is so tight, so please let us know if you have questions here about the types of programs you're thinking about, and just any clarity on the examples that were shared.
Yeah, and
go ahead.
There's a question in the chat. Would you prefer to see applicants present a strategy that fits one of these bullet points, or is it critical to hit multiple points?
That's a great question. It's not critical to hit multiple points. If you have a program that does, that's amazing, and would love to see it. But no, we just wanted to give examples under the different categories of preventative services.
So can you hear me? This is Nancy Gottlieb.
Yes.
From CADA. We provide quite a few services, perinatal and parenting, working with adolescents and adults with substance use and mental health difficulties. And I could see that we could help mitigate working with parents and family members and doing parent education. Would those be separate proposals, or we would propose to sort of navigate and coordinate that care and then bill for those services separately under Medi-Cal? Is that what you mean by not charging them to the grant?
I think that the parenting supports, parenting classes, those kinds of things are allowable, and you would be using the grant funds. But if there are things that you are already billing to Medi-Cal, we could not fund those services. So if there's services that go ahead.
So if they're participating in substance abuse treatment, have kids that have been identified, and we're now going to provide parenting and peer supports, then we could bill the peer and the parenting supports, which are not billable under Medi-Cal.
Absolutely.
Medi-Cal.
Yeah.
Okay. So because I think we have a lot of services that would benefit parents and family members of kids who have been identified as having troubles in the home.
Anna, another question in the chat. Would the families that we serve have to have a diagnosis or a screening before we provide services like parenting support?
No. So I think the screenings are happening at the pediatric clinics. And so we want to ensure that there's that's the coordination piece. We want to ensure that you have a process in place or can demonstrate how you can receive referrals once families are screened and are needing the types of services you offer. But in addition, you could be serving a broader population that has not been screened for ACEs, but we want to know that the population you are serving are likely to have ACEs, right? So you're working with a population that potentially has those needs, even though the screening has not occurred. So being able to demonstrate the population you're serving and the likelihood that those children and families would have a greater likelihood of being exposed to ACEs and toxic stress. Barb, does that gel with what you're thinking as well?
Yeah, definitely. I mean, I think we don't want to limit it to people who've already gone through the screening process, but as this work expands, more and more families will be exposed to the information. So we just want to make sure that there's clear communication that if there are patients who are at the clinics that need referrals, that those referrals are open to them, but that it wouldn't be limited to just those folks. We want applicants to have a relationship with one of the clinics that's listed in the RFP. And the integration piece is important. Working with multiple partners is also important, but doesn't have to be limited.
Other questions? If not, I will move on.
This is Linda from CADA. Is there an expectation that we, in addition to receiving referrals from the clinics, we would also do our own screening and outreach?
No, so we're not expecting that you're doing any ACE screenings, but outreach, I think, yes. I mean, I think, so there will be some referrals coming directly from our clinic partners who are conducting the ACE screening. And then we also just want to understand how you're targeting other patients or other community members who would benefit from your services, even though that doesn't need to require an ACE screen. But again, wanting to understand how your outreach efforts are really targeting those families that might be most vulnerable to having been exposed to adverse childhood experiences or toxic stress.
So we could outreach to Sampson adult treatment programs, for example, internal medicine or something. Or only to pediatric resources. I had a question in my chat, so.
Yeah, so the services, I believe, we're focusing on the pediatric population and their families. So this would be, so your outreach, I think, similarly would align to that population.
Okay.
So children and youth, I think we define children as to age, I forget, Monica, we've defined this before. I think it was either 18 or 24 and the family. So children and adolescents are all included.
Yeah. I mean, I think for the purpose of this, we may want to stick to age 18. I think we have gone up in other situations to age 24. Not sure if any others, like Dr. Dodds, have any thoughts on that.
Generally, most pediatricians would do the cutoff at 18, knowing that that sort of 18 to 24 age group is sort of an in-between group. But then you're starting to also look at people who are having their own children. So it gets it just gets more complicated. So I think at this point, it makes sense to say 18.
Yeah.
And there's another question in the chat. I think, Nancy, feel free to chime in if you didn't have your question answered, but I think we did. And then Lori mentioned, are we expected to have a pre-existing relationship with one of the clinics, or can we build those relationships over time?
Definitely. I think that the goal of this grant is to help build those relationships. I think is definitely encouraging if you already have those relationships, and it's something to highlight in your application, but that's not a prerequisite. I think we are realizing that there's still work to be done to better connect our community partners with our clinic partners. And so this grant is a step in that direction.
And I'll just say that we really are interested in the buffering resources. And so, if some clinics have services in-house, and so we wouldn't want to be duplicating the services that they're offering in-house, but linking them to something additional that their families and their patients could benefit from. So thinking back to that stress busting wheel and all of those buffering resources, that's where we want to make sure that we're offering them something that they're not already doing.
I'm going to keep going, and we'll make sure we still leave time for questions at the end. So I just wanted to share that the broader Network of Care implementation grant has some evaluation metrics that we're looking at. We're looking at increased knowledge and awareness of ACEs and resiliency education, as well as the impact of resilience on toxic stress. We're looking at confidence and self-efficacy to seek services and support, increasing participation in these interventions and services that we're making available, as well as increased understanding of preventing approaches to ACEs. We're looking to see improved coordination of care between medical, behavioral, and social services, and decreased barriers to families receiving behavioral health and social services. So just wanted to share those because I think this is a piece of that work. And so what we're learning as you share some of your data, and we'll talk about what those reporting requirements are, it really is in service of this larger evaluation effort that we'll be reporting back to the ACEs Aware Initiative as a part of our grant deliverables. In terms of this grant program, this buffering services grant, we're asking that you share some quantitative data, like those number of individuals who are referred from the clinics, as well as the number of individuals you're reaching through community referrals. So being able to distinguish between those that are coming from the clinics that you identify that you'll be receiving referrals from, and then other outreach efforts that you have for referring community residents to your program. And then also looking for you to report number of individuals who've successfully completed your program and services, and improvements in their well-being as measured by any relevant assessment tools that you're using as a part of your program. And we'll be looking to have this information reported quarterly, and we'll provide a template. Again, we're just wanting to see how many referrals you're receiving, how many individuals successfully complete your program, and then any assessments data. And we understand, especially with the assessment data, if you're doing pre and post assessments as individuals complete your program, that may not be available monthly, and that is fine. And then additional reporting is qualitative data on what does success look like, what are you connecting and coordinating, how are you connecting and coordinating with the clinics, and then how are you doing outreach beyond the clinic referrals. And this information we're looking to collect as a part of your midpoint and end of grant reporting. So we'll have template for those as well, where you can share that qualitative data, but we want to ensure that you're collecting it so that you are ready to report that at midpoint and at the end of the grant. So these are our clinic partners that we are working with, and we're looking to send referrals from. And so we're asking that you identify in your proposal which clinic or clinics you'll be you would be working with or be available to receive referrals from. And some of this may be based on your own geographic limitations or how you are, how you're currently implementing your program. Others may have a broader scope and can work with multiple clinics. And I don't think there's no penalty for only being able to receive referrals from one clinic. We just need to clearly identify which clinics you'll be able to receive referrals from. The maximum award is $50,000 over a 6-month period. We know it's a short time frame. I think we are definitely open if it occurs and you're needing a no-cost extension, that will be available. The grant period is from August 1st to the end of January. And indirect costs must not exceed 10% of your project budget. Non-allowable expenses include things like capital improvements, direct patient care services. And again, what we mean by direct patient care services are those services that are reimbursable through Medi-Cal. So that does not mean that things like parenting supports and support groups, because you're working directly with patients, those are allowable. The only thing that isn't allowable is if those services are reimbursable through Medi-Cal, and of course, alcoholic beverages. So, what are we looking for? I think ideal projects are those that are, again, offering those services that help mitigate the toxic stress response. So as Barb said, really looking at that wheel and seeing where your program fits in. And being able to demonstrate how you're offering those services and creating access, and can create access to our clinic partners or the patients from our clinic partners. Thinking about that coordination piece. So how are you set up to receive referrals and integrate those patients into your program as well? And of course, having some evidence-based or best practices that support your program or the strategies that you're using. Additionally, we're looking for a project that can collect the data that we just went over, ensuring that you have processes set up that would make it easy for you to report the quantitative data on a monthly basis and that qualitative data at the midpoint and end point of the grant. And then also being able to talk about the sustainability of your program. We're not anticipating that your programs are fully sustainable, right? As we understand the challenges with that, but that you're able to talk about your efforts towards sustainability. Those who are eligible for this grant program include nonprofit organizations, but then also for-profit organizations that are partnering with tax-exempt organizations, but are acting as a fiscal sponsor. And our timeline today is the application webinar. We are providing technical assistance through the 25th. You'll be able to make an appointment through either our Listen Pop Health email address or connecting with our wonderful administrative assistant, Leah, and we can make that information available. I believe it's also available in the RFP and application. So we can set up 30-minute calls to talk through any specific questions that you have about your program. The application is due next week Thursday by 5 p.m. Grantees will be notified July 15th, and the grant cycle begins August 1st. Again, this is a 6-month grant cycle. We're asking for midpoint reports, sharing some of that qualitative data November 1st, and again at the end of the grant, February 28th. And we will be offering a second grant cycle opportunity. So offering it for this 6 months, but there's opportunities to continue on for another 6 months. I'll pause there to see if there's any questions before I go into the application itself. So the application is a Word document. We're hoping that you will kind of use that template and not make any changes to the template or the questions. We're asking that you use 12-point font. And of course, I mentioned keeping the original questions, and limit it to 4 pages. We really want this to be a quick and easy application process for you all. So please, and also being able to turn around the grants quickly. It's important that you stay within those grant pages. That does not include the attachments or your cover page. So attachments for the grant, for a full grant application, we're asking that you share a list and description of the key staff, list of officers and board members, detailed program budget and detailed agency budget, most recent audit financial statements, and a copy of your IRS tax exempt letter. Okay. So again, all of those pieces in addition to the application would make a complete application. So the application starts with just you telling us a little bit about who you are. So sharing some background on your organization, history, and main accomplishments. Again, really keeping this brief. I'm sure many of you have some write-ups like this that you've used in other grant applications. And so we encourage you to use what you have, and hopefully this is something that you already have to pull from to complete this section of the application. Next, we want you to tell us a little bit about what you're going to do. And so here we ask that you describe your program, include the clinics that you'll be able to receive referrals from, and the strategies that you'll be offering, and how you plan to successfully connect with patients once they're referred for services. And then also demonstrate or share the evidence base that supports your program. And again, yes, please go ahead.
I was going to say, should I hold questions or interject?
No, please go.
Thanks. Thank you. Michelle from Wilderness Youth Project. Curious about, just given that there aren't specific word counts or character counts for these sections, can you give us a general framework specific in particular for this question that we're looking at right now about evidence base? Sort of about what length of response are you looking for here?
Really, I imagine that the evidence base could be maybe 3 paragraphs or so, really brief, just a quick summary of the evidence that supports your program, whether it be lived community member experiences that you've collected, data that shows the need for your program, or you have literature that supports the, like evidence behind the program and strategies, but really brief summaries of it. So not like a full literature review, just really hitting the key points of the evidence that supports your program.
Got it. Thanks so much.
Yeah, that's a great question. I think where you may want to spend the most time is around describing your program and really making sure that you are clearly identifying kind of what kind of buffering service this is, how this service helps to interrupt the toxic stress response, the clinics you plan to serve, and how you're going to create that connection once patients are referred into your program, and in addition to those you're serving in the broader community. I feel like it's one of the more important pieces of this application, really making sure that part is clear. So then we also just want to understand how you measure impact. So with your programs, any methods, data you're collecting, and who's responsible, just want to understand how you're currently measuring the impact of your program, and just demonstrating that your program has the capacity to do that, in addition to reporting the data that's required monthly, as well as the qualitative data that's required for those midpoint and endpoint reports. And then, of course, want to understand how the funds will be used. So please include a list and definition of funded items and categories, the amount you're requesting, and again, a brief paragraph or so about just your plans for sustainability. And Monica, would you add anything else here around the budget piece?
No, I think that's it. I think the most important thing is that itemized list. And it's important, I think, when you're thinking about your items is that, the category or the item, the amount of that request, and a very brief description, like one sentence or less that just defines that. It's oftentimes tricky to match that up, but if you can link the dollar amount with that item in this section and then the total amount of your request.
Thanks for that, Monica. And so we went through it briefly. We tried our best to make this RFP and application as streamlined and simple as possible. Again, understanding what a tight turnaround this is. I hope that's reflected in as you were looking at the application and the RFP.